Welcome to Lactation Education for Healthcare Providers. This module, entitled Evidence-Based Research on the Treatment of Mastitis and Other Breast Conditions. My name is Kara Rick. I am a graduate student in Arizona State University studying for my Doctor of Nursing Practice, otherwise known as DNP degree. I'm a registered nurse. I'm also a LHLA leader. My interests are in breastfeeding medicine and improving the care provided to mother-baby dyads. Myself, along with Renee Moore, who is an international board-certified lactation consultant, will be presenting this module to you. Neither Renee or I have any disclosures to make. So let's get started. The objectives for this presentation are to differentiate between candidiasis, mastitis, and breast abscess, identify methods for caring for a mother with mastitis, identify methods for caring for the mother-baby dyad with candidiasis, and identify a breast abscess, recommend appropriate treatment, and describe the role of the IBCLC and how to utilize their care. Hopefully, after viewing this presentation, you will feel more confident in treating conditions of the breast and providing care for the breastfeeding dyad. Let's get started. We know that Candida is a fungus normally found in and on the body in small amounts. It is present on the skin, in our mouths, as well as our intestinal tract and genitalial area. Most of the time, Candida does not cause any symptoms, but when these organisms overgrow, they can cause infection, also known as candidiasis or yeast infection. Right now, we want to focus on caring for the mother-baby dyad who may appear with a candidiasis infection, specifically thrush in the mouth of the infant and candidiasis on the nipple. Here in this slide, I have noted some causes of candidiasis infection. It is important to get to the root cause of the infection to prevent recurrence. Babies may also have candidiasis in their diaper area, and that may need to be treated as well. Mom and baby should continue to breastfeed through the course of treatment. It is important to note that if either mom or baby has thrush, that a thorough assessment of both mom and baby should be performed. A typical statement from a mother with candidiasis of the breast would sound something like this. I have a burning, itching craziness on and off on my nipple. The white portion comes and goes, occasionally becomes shiny and red. The itching comes and goes too. Sometimes it goes away for several days and I get my hopes up, but then it returns. I want to rip my nipple off. It makes me want to crawl out of my skin. Looking at the images on your left, you see two different breasts with candidiasis infection. Notice on the upper left photo the white spots on the tip of the nipple. If you were to try and wipe or wash the spot off, it would most likely not come off, and if it did, it would leave a red, shiny, possibly bloody mark behind. Looking at the picture on the lower left, you see a shiny red nipple. Oftentimes, mom will also complain of flakiness of the nipple. The hallmark signs you want to look for in diagnosing candidiasis of the nipple are red, shiny, and itchy. A baby with symptoms of thrush may have white patches surrounded by diffuse redness in their mouth. Spots may appear on the tongue, on the palate, or inside of the cheek. Most babies will likely be fussy and refusing the breast because having an infection in your mouth, it doesn't feel good. Looking at the images on the right, you will see two different examples of infants with oral thrush. As with the breast, if you were to try and wipe the white spots out of the baby's mouth, you would likely not be able to do so. And if you were, you would be left with a bloody, red, very inflamed patch. Thrush can occur throughout the oral cavity. Other point that I want to make about thrush is that it's differentiated from having a tongue that's covered with breast milk. So when you look in a baby's mouth, oftentimes they will have a white tongue because they've just got done with the feeding. If you look at these pictures with infants that actually have thrush, you see that there are spots there and they really aren't easy to remove, and they are there at all times. They don't come and go. So how do we treat thrush? Evidence-based research by Nancy Moorbacher and Dr. Ruth Lawrence on treating candidiasis states that both mom and baby should be treated for a period of 2 weeks. It is important to try and assess the cause of the candidiasis and try to prevent reinfection. In the case of antibiotic usage, treatment for candidiasis can overlap with antibiotics, but treatment for candidiasis should extend beyond antibiotic usage. The American Academy of Pediatrics recommends the use of nystatin oral suspension to be used on babies. After a feeding, mom can swab baby's mouth and apply the oral solution. For breasts, mom should apply a topical antifungal such as clotrimazole before and after breastfeeding. If a mom is experiencing a systemic yeast infection, diflucan can be helping to clear out the infection throughout the body. It is extremely important that all objects that have been put in the baby's mouth, including teethers, pacifiers, and bottle nipples, be sterilized in boiling water for 20 minutes. Recolonization from unsterilized items is quite common. Mom must also be mindful of keeping nipples dry and washing and/or discarding breast pads after they become wet. Evidence-based research suggests mom take a probiotic daily, especially if going back on antibiotics, to prevent recurrence of the candidiasis. If antifungal treatments are not successful in clearing up the candidiasis, Gentian Violet can be used. Gentian Violet needs to be applied to both the mouth of the baby as well as the breast of the mother. The picture on the right shows a baby after Gentian Violet has been brushed in the baby's mouth. Just be aware, Gentian Violet can be very, very messy and get all over the place. So if you are prescribing this to moms and babies, make sure you let them know that don't wear your best clothes. Don't put it on the sheets because it's really difficult to wash out. Now let's talk about mastitis. Ideally, we would like to get treatment for moms before the development of mastitis. Therefore, it's important to talk about the root cause of mastitis and how to treat those symptoms before mastitis develops. It is not always possible to treat symptoms before they develop into mastitis because we may not see the patient may not be aware of symptoms leading up to mastitis, whatever reason it is. But if you have an understanding of what causes mastitis, it can be very helpful in diagnosing the condition and or treating the condition to prevent recurrence and development of mastitis. I'm going to talk about 3 different conditions that lead up to mastitis: milk stasis, engorgement, and plugged ducts. Let's get started with milk stasis. Milk stasis, which is an incomplete emptying of the breast, typically occurs due to poor suck and or latch, scheduled feeds instead of feeding on demand, and milk synthesis that exceeds the baby's ability to remove milk from the breast. Milk stasis and engorgement sometimes go hand in hand. The best resolution for milk stasis is to early, frequently, and effectively breastfeed. Babies need to have an effective latch and suck response in order to remove milk. Some causes of milk stasis are often linked to the baby. Oftentimes, baby will have ankylosing, otherwise known as tongue tie, which will be further discussed in depth in a different learning module. Or sometimes an illness in mother and or baby can result in milk stasis. For example, baby may have a cold, may be very congested. Just as you and I feel terrible with cold and congestion, babies feel bad too. Baby may not nurse as often, causing milk stasis in the breast. It's important to remember that breastfeeding works by supply and demand. If a baby or mom is pumping or hand expression is removing milk from the breast continues to make milk, somewhat close to the rate that is being removed from the breast. If the demand goes down, supply goes up. This is what causes milk stasis. If milk is not effectively removed from the breast for a period of time, engorgement will occur. Plugged ducts can occur at any time through this process, and both of these eventually lead to mastitis. Another danger of not effectively removing milk from the breast is involution, which results in a decreased capacity of stored milk and ultimately decreased milk production. Some moms are able to ramp up milk production, while for others, involution is irreversible and they're not able to get their supply back up. So we want to make sure that if a mother is presenting to us with milk stasis and engorgement, we are helping them to solve the problem, to figure out how to get milk out of the breast so it doesn't lead to involution, so it doesn't lead to low milk supply and more problems for the mother-baby dyad. Now let's talk about engorgement. Engorgement is very common in the early postpartum period as breasts are increasing milk production rapidly due to hormone shifts from giving birth. Engorgement typically occurs 3 to 5 days postpartum. Women can also become engorged after a long duration of not breastfeeding or become engorged due to an abrupt weaning of baby. On examination of a mother experiencing engorgement, you will find that her breasts are very firm and possibly knotty, where milk ducts are filled with milk. She will describe her breasts as being very tender and painful. Baby may have a hard time latching onto the breast because of the fullness of the breast. Hand expressing milk from the breast can be extremely helpful to allow baby to latch on. Breast massage as well as milk expression, either by breastfeeding baby, hand expression, or pumping, will help to relieve engorgement. It is advised that moms do not start pumping their milk until baby is 6 weeks of age unless medically indicated. If a mother is pumping her milk, in addition to feeding her baby, she may develop a large supply of milk and increase her risk of developing engorgement and/or milk stasis later in breastfeeding if she does not gradually decrease milk removal from her breast. Again, the supply and demand idea. Treatment for engorgement includes breastfeeding the baby, often and on demand, using cool compresses to the breast between feeds, anti-inflammatory medications such as ibuprofen, and warm treatment to the breast before breastfeeding to help with milk removal. Engorgement typically resolves itself in 3 days of onset. If it's not resolving itself, there could be some other issue going on and you would want to address that and do a thorough assessment of mom and baby. Now let's talk about plugged ducts. Nobody knows the specific cause of a plugged duct, but often we see that they are found in mothers who have an abundant milk supply and who do not adequately drain their breasts. So going back to the milk stasis idea. Plugged ducts are thought to be an accumulation of milk and/or dead cells. A mother will oftentimes describe a plugged duct as being a tender and possibly warm to the touch area localized to a very small area on the breast. On examination, you will see redness localized to an area of the breast and feel a palpable lump with well-defined margins. A mother with a plugged duct will not have a fever. Plugged ducts may also appear as a bleb or milk blister on the nipple, as you can see on the picture in the lower right-hand side. Treatment for a plugged duct is to continue to nurse and drain the breast completely. This may require the mom to pump her breast after breastfeeding. Warm compress to the affected area and breast massage can also be very, very, very helpful in removing a plugged duct. Oftentimes, mom will report a long, stringy, white product coming out of the nipple after a pumping session, followed by relief of their symptoms. If you look at the picture on the right side in the upper left quadrant, you kind of get a picture of what's going on with a plugged duct. That there's a duct in the breast and it's filled with, either lipids, dead cells, milk and whatnot, and to relieve it, pumping, breastfeeding the baby, and then that helps to pull out that junk and it comes out more almost like a clot. Mothers with chronic plugged ducts may benefit from taking 1,200 milligrams of lectin 3 to 4 times a day. Lectin is hypothesized to act as an emulsifier to help break fats in the milk that may be causing the ducts to plug. Now that we have some idea on the conditions that cause mastitis, I want to talk about how we are going to prevent mastitis. As a practitioner, if you are able to notice the previously noted conditions, milk stasis, engorgement, plugged ducts, you will be able to play an active role in preventing mastitis from occurring. Asking your patients questions such as, how's baby's latch? How do your breasts feel before and after feedings? Do you have nipple pain, breast pain? Are you feeding your baby on demand or are you scheduling feedings? Asking these questions will give you some clues as to how the nursing relationship is going. If a mom is experiencing pain, baby's latch is not correct, if mom is experiencing other breast issues, troubleshooting these issues and working with an international board-certified lactation consultant, otherwise known as an IBCLC, to troubleshoot these problems will be helpful to preserve the breastfeeding relationship. If there is anything you take away from this lecture, it's that moms and babies should continue to breastfeed despite the conditions that we have. That you as a practitioner play an active role in supporting breastfeeding and supporting the breastfeeding dyad. The more knowledge you have, the more knowledge you are able to share with your patients and able to provide them the care and the support that they need. So what do we do if everything that we have done to try and prevent mastitis, mom still comes to us and develops an infection? It happens. Though research is showing that the incidence of mastitis is decreasing, possibly due to mother's awareness of milk stasis, plugged ducts and engorgement, and seeking treatment before they become ill, we still need to know how to treat mastitis, and we need to be very aware of the condition so that we don't move on and develop something more serious such as breast abscess. The Academy of Breastfeeding Medicine has a wonderful protocol that I will discuss regarding the treatment of mastitis. This protocol outlines the definition, diagnosis, predisposing factors that we have previously discussed, management, and follow-up for the mother-baby dyad. The website that hosts this module, Lactation Education for Healthcare Providers, has a link to this protocol if you would like to download it, as well as links to the Academy of Breastfeeding Medicine protocols. They have about 22, 23 different protocols that cover a variety of conditions related to breastfeeding and the mother-baby dyad. I would like to note that the Academy of Breastfeeding Medicine periodically updates their protocols. I would highly suggest bookmarking their page, which is linked in the additional resources, and access it often if you have questions about breastfeeding. What is the definition of mastitis? The clinical definition of mastitis is a tender, hot, swollen, wedge-shaped area of the breast associated with a temperature of 38.5 degrees Celsius or 101.3 degrees Fahrenheit or greater. Chills, flu-like aching, and systemic illness. Mastitis literally means an inflammation of the breast. We have previously talked about some causes that will lead to mastitis, such as engorgement, milk stasis, and poor latch and plugged ducts. Additional causes of mastitis are damaged nipples, especially those colonized with Staphylococcus aureus. Maternal fatigue and stress are other issues that cause the immune system to weaken, potentially leading to the formation of mastitis in the breast. The image on the right gives you a bit of an idea of what mastitis will look like in the breast. The picture on the next slide will give you a better visual of what you may see in the clinic. It is important to note that these pictures are mere examples. Seeking the entire story through discussion and examination of the breast and baby's mouth will ultimately give you clues to the full picture of the patient's illness. Please note that untreated mastitis leads to breast abscess. Please be vigilant with your diagnosis and treatment of your patients. Ideally, you want to save and preserve the breastfeeding relationship. This image gives you a better idea of the clinical presentation of the breast. You may see red streaks on the breast, as noted in the image, as well as red, swollen, wedge-shaped area. This breast appears also to be engorged. Moms are typically in pain and they feel miserable. I've had patients tell me that their experience with mastitis is the sickest they have ever felt in their entire lives. Even when moms are feeling miserable, the best thing they can do is breastfeed their baby to aid in the emptying of the breast. So, how do we treat mastitis? There are 3 aspects to the plan of care: effective milk removal, supportive measures, and pharmacological management. As I have previously discussed, removing milk from the breast and preventing milk stasis is imperative. Enlisting the help of an IBCLC to troubleshoot latch issues, work on positioning of the infant, teaching and performing breast massage, and teaching hand expression of the breast can be extremely beneficial and crucial to helping resolve the mastitis and prevent reoccurrence. Supportive measures for mom include rest, adequate fluids, and proper nutrition. Mothers may also require practical help in the home to allow them to obtain the proper rest that they need. Talking about getting the help they need to help their body to heal is fundamental. An IBCLC can also be helpful with this aspect. If a mother requires hospitalization to treat her mastitis, it is imperative that the baby rooms in with the mother to continue breastfeeding. Some hospitals may require baby is admitted as a patient as well. It is very important to know your hospital and know what steps you need to take to ensure that proper support is given to the breastfeeding dyad. At no point during the treatment of mastitis should mom and baby be separated. If mom has a mild case of mastitis and the symptoms have only been present for less than 24 hours, conservative management and effective milk removal will help to resolve the mastitis. If symptoms have not improved within 24 hours, antibiotics should be started. The most common pathogen worldwide that causes mastitis is Staphylococcus aureus. The preferred antibiotics are penicillinase-resistant penicillins, such as doxycycline or fluoxetine. Another option is a first-generation cephalosporin. If a penicillin allergy is noted, cefalexin is generally considered to be safe, as well as clindamycin. Antibiotics should be prescribed for 10 to 14 days. As a provider, you should follow up 48 hours to see if symptoms are starting to resolve. If symptoms are not starting to resolve, mom needs to come back to your office immediately. So, what about the follow-up that we're going to do with this mom and baby? The World Health Organization recommends bacteriological testing for unresolved and or recurrent cases of mastitis. So if you have a mom coming into your clinic, you've given her antibiotics, 48 hours later she's not feeling any better, her breast is not changing at all, you can do a culture to see if you can figure out is the antibiotic you're prescribing in the spectrum. Why is she not getting better? Breast milk culture and antibiogram is recommended for determining the most appropriate treatment for mastitis. Basically what you do is take a sample of her milk and send it off for culture and screening. And this should tell you what the bacteria most likely is and what antibiotics you should use to treat the infection. You should be aware of the complications of mastitis. The next slide will cover these in more detail. As a practitioner, you should inquire about any new onset of breast symptoms after the treatment of mastitis. This includes new onset of pain, changes in sensation of the breast, changes in the skin of the breast. You will want to examine and palpate the breast after the completion of antibiotic therapy to make sure that the breast is completely healed and there are no other unresolved issues. Examining the entire breast, examining the nipple, looking for cracks, feeling for lumps, anything that might be out of the ordinary. So, complications of mastitis. There are 3 main complications that you should be cognitive of when treating a mom with mastitis: early weaning, candidiasis, and abscess. Mothers who experience mastitis symptoms are more likely to abruptly wean their babies due to the overwhelming acute symptoms: fever, chills, and the flu-like symptoms. If you have previously experienced mastitis, you are probably well aware of the awful, awful feeling. I can tell you that I have previously experienced mastitis, and it was hard. It is extremely important to counsel mothers and encourage them not to wean their babies. Get the rest and nutrients their body needs. They, as well as their baby, will benefit from continuing to breastfeed. It is important to get to the underlying cause of mastitis. Mom should continue to breastfeed from both breasts. And I can tell you, if mom chooses to wean, if mom chooses to only breastfeed from one breast, this can exacerbate the mastitis because you are creating more milk stasis, allowing for more of that bacteria to flourish on that tasty milk that her breast is making. And that's what leads to the abscess, because you're not draining out the fluid that is in her breast. That's why continual breastfeeding, putting baby to breast, hand massage, pumping, hand expression are extremely, extremely important to helping clear up mastitis. I have previously discussed candidiasis. It is important to be mindful of the possibility of a mother and or baby developing candidiasis due to antibiotic usage. Taking a probiotic while using antibiotics has been shown to decrease the likelihood of this happening. During the follow-up, it is important that you ask about the wellness of the baby. Is baby more fussy? Any changes in baby's stooling? Any development of spots in the baby's mouth? Antibiotics are typically passed in small amounts through breast milk and can affect the baby in similar ways that they affect the mother. This does not in any way mean that you should not prescribe antibiotics or mom should stop breastfeeding baby. Antibiotics will not harm the baby. Assessing mom as well as baby and initiating prompt treatment for symptoms will help to preserve the breastfeeding relationship and prevent further complications. Abscesses occur in about 3% of mothers who develop mastitis. I'm going to go over abscess in the next section. I know that I have discussed prevention of mastitis in previous slides, but it is so important that I'm going to go over it again. The most important thing a mother can do is breastfeed her baby on demand. Mothers should effectively manage breast fullness and engorgement. Contacting an IBCLC can be extremely helpful. Latch of baby should be assessed. Methods of milk removal should be assessed. The picture on the right is of a newborn baby breastfeeding. This baby has a great latch and is effectively removing milk from the breast. Mothers should give prompt attention to signs of milk stasis. If a mom notices any signs of milk stasis, she needs to increase breastfeeding frequency, apply heat to the breast, and massage her breast for effective milk removal. Mothers should be taught to check their breasts for lumps, pain, and redness and tenderness almost on a daily basis. Mothers should pay prompt attention to their difficulties with breastfeeding. Mothers should address their issues such as damaged nipples and contact you if symptoms do not resolve within 24 hours. Mothers also need to make sure they are taking care of themselves, getting proper rest, staying hydrated, and getting proper nutrition. Asking mothers if they need help at home can also be helpful. Providing mothers with community resources such as La Leche League can make a huge difference to a mom. Knowing that you have somebody to talk about your breast issues with, knowing you're not the only one, and being able to share your experiences can be very helpful for a mother to not only continue breastfeed, but also for them to resolve some of the issues they may be feeling within themselves. Mothers need to be very mindful of good hygiene. They need to be changing their breast pads often, thoroughly washing breast pump equipment, properly sterilizing bottles and pacifiers. As I discussed, if a mother has mastitis or specifically candidiasis, boiling anything that goes in the baby's mouth for 20 minutes. If you, as a practitioner, know the causes of mastitis, it will be helpful for you in solving the underlying causes. It is also having a great IBCLC to discuss patients will be extremely helpful in troubleshooting mother-baby issues. Asking questions and not making assumptions is very important. Now that we've discussed mastitis, let's talk about breast abscess. It is my hope that you will never ever see a patient with breast abscess and that you will be able to help clear up any symptoms of mastitis or the conditions leading up to mastitis before the formation of an abscess. But if you do come across one, it's important to be able to recognize the signs and symptoms and promptly treat and refer mother out to prevent further complications and really to help preserve the breastfeeding relationship between mom and baby. As you probably know, an abscess is a collection of pus that must be drained. An abscess is a well-defined area of the breast that remains red, hard, and tender despite appropriate management for mastitis symptoms. Mothers who have an abscess are typically clear of fever, though it is possible that they may still have one, even because they have not sought treatment for mastitis. As you look at this picture, you can see a well-defined red area of the breast. This area is very, very tender and very painful for mom. If you recall the mastitis images, the breast was reddened with streaking, but a well-defined area was not seen, which is definitely present in the image you see here. So, how do we treat breast abscess? Most often, you will refer your patient out to a breast specialist or general surgeon to drain the abscess. It can be helpful to know the providers in your area to make sure you are sending your mother to someone who is able to provide treatment for their illness and someone who has a great deal of experience. Evidence-based research by Katrina et al. And Yu et al. Strongly recommend surgical removal of an abscess as a very last resort. Fine needle aspiration using guided ultrasound is the recommended treatment. The image on the right is a picture of a patient with a breast abscess and the ultrasound image of the abscess showing a large mass and purulent material. Another note about breast abscess is that these patients need to be on antibiotic therapy until the abscess heals. So if you recall from my discussion about mastitis, we want to give them a similar antibiotic that I discussed in that section. The two articles listed on the screen are excellent references in the treatment of breast abscess. I've included both of these articles in the reference section if you would like more in-depth knowledge about the treatment of breast abscess. As a provider, the one thing you can and should do for a patient with breast abscess is to encourage them to breastfeed their baby. Babies can and should nurse on the affected breast as often as possible. Even if there's blood or drainage to the nipple, the qualities of breast milk will help to protect the baby. One note of caution. It may be difficult for a mom with a breast to breastfeed if the incision and drainage is very close to her nipple. You may want to make sure you are preserving the milk supply for the baby. You will want to refer mom to an IBCLC for further evaluation of the possible reasons leading up to abscess, such as poor latch, poor positioning, and whatnot, and help mom to take steps to prevent formation of a further abscess or mastitis on the other breast, and also help with stimulation of the breast to maintain her supply while the wound heals. Things like breast massage, hand expression from the breast are totally acceptable to a breast that has breast abscess. Ideally, you will have enough knowledge to be able to manage and treat the breastfeeding diet before an abscess develops. Now that we've talked about mastitis, candidiasis, breast abscess, I'm going to go over a few other conditions that you may see in a breastfeeding mother and discuss their treatment options. It is good to have a reference of various conditions that you may see in practice and to give you some background on how to treat these conditions. One of the more common things you will see in a breastfeeding dyad are cracked nipples. Nipple pain and/or cracked nipples are most common reasons mothers discontinue breastfeeding. Here you see two of the more extreme cases of cracked, bleeding nipples. For mothers, this is extremely painful. The biggest cause for cracked and bleeding nipples is a poor latch or suck of the baby. Improper positions can also contribute to cracked and bleeding nipples. An IBCLC has extensive training on helping mothers with cracked, sore, or bleeding nipples. If you see this in your practice, you should consult with an IBCLC right away. Actually, encourage mom to consult with an IBCLC right away and encourage mom to seek help from a lactation consultant to correct the latch of her baby. As a practitioner, you will want to provide some guidance on how to treat and heal cracked nipples, and also provide encouragement and support for mom to continue to breastfeed her baby. As a provider, you should have some basic knowledge about positioning of baby to breast. I'm not going to go over that in this lecture, but there is a great discussion on positioning in the breastfeeding and general knowledge module. Also, being aware of what a good latch looks like and sounds like can be extremely helpful and beneficial in preventing cracked, sore, bleeding nipples. So, how do we treat cracked nipples? I want to add that IBCLCs have extensive training on providing treatment for cracked nipples, so utilizing their knowledge and expertise can be very beneficial to preserving the breastfeeding relationship. First line of treatment for cracked and bleeding nipples is saline rinse of the nipples after breastfeeding. Additional treatment options to help clear up cracked and/or bleeding nipples include silver nipple shields that you see here, silicone nipple shields, brush shells, and all-purpose nipple ointment. Silver nipple shields can be helpful because silver is a well-known healing and antibacterial properties. Silver nipple shields are worn when mom is not breastfeeding. While mother is breastfeeding, she can wear a silicone nipple shield to protect her breast from further damage. If we are to employ the use of a silicone nipple shield, I would do so with the help of an IBCLC. Brush shells can be worn to protect the nipples, similar to the silver nipple shields. Brush shells are currently more readily available than the silver nipple shields and are also less expensive. They prevent clothing from rubbing up and against sore nipples. If you have a mother with cracked, sore nipples that are not healing from other measures, you will want to consider prescribing all-purpose nipple ointment. Dr. Jack Newman, a breastfeeding specialist in Canada, designed this recipe to treat a variety of conditions that can cause nipple pain, infection, candidiasis, and inflammation. All-purpose nipple ointment consists of mupirocin ointment 2%, 15 grams, betamethasone ointment 0.1%, 15 grams, and added miconazole powder to a concentration of 2% miconazole. A mother will need to get this prescription at a compounding pharmacy. Mothers will need to apply just enough ointment to cover the nipples and areola to make them glossy after each breastfeeding. You will want to advise mothers to not wipe off the ointment when bringing baby to breast. Eczema is another more common condition that you will see in the breastfeeding woman. Eczema is characterized by painful, burning, itching dermatitis with redness, flaking skin, and sometimes crusting and oozing papules. Eczema can easily be confused with candidiasis. The hallmark difference between eczema and candidiasis is that with candidiasis, you will typically see shiny skin. If you look at the pictures on the right, you will see that the skin is dull. And if you are entirely unsure of the reason for for the reaction on the nipple, if it's eczema or candidiasis, you can always prescribe the all-purpose ointment that I mentioned in the previous slide, as the components heal both candidiasis and contains a corticosteroid to help with the eczema. There are two main causes for eczema, and knowing this should help you differentiate between candidiasis and eczema. Eczema on the nipples oftentimes appears on mothers who have a history of eczema. The nipples become more sensitive after birth of the baby, and therefore eczema may appear. You may inquire if the patient has eczema elsewhere on her body and ask if she has a history of eczema. The other main cause of eczema is reaction to the baby's saliva after the introduction of solid foods. In this case, it is important for mom to figure out foods baby is eating that may cause this reaction. Rinsing the nipple and areole with mother's expressed milk and water, then patting the area dry may also help alleviate the irritation. Treatment for eczema on the nipple is applying a corticosteroid cream. It's important to note that if you're only using a corticosteroid cream to treat the eczema on the nipple, mom will want to wipe off the corticosteroid cream before breastfeeding the baby. As with all other conditions that we have talked about, breastfeeding should continue. It is always important to preserve the milk supply. Another condition that you might observe in clinic with a breastfeeding mom is Raynaud's phenomenon of the nipple. Raynaud's phenomenon is more commonly discussed and noted in the hands and feet of individuals. Raynaud's is a disorder that affects the blood vessels, typically at the end of an extremity, causing the blood vessels to narrow as a result of cold and/or stress. A woman may describe her feeling as a vasospasm of her nipple. Oftentimes, mothers will present to you with nipple pain, most noticeably after a feeding. When you examine the breast, you will most likely not find anything out of the ordinary. If a nipple is exposed to cold, you will witness something similar to what you see on the image on the right. The nipple begins to turn white as it is exposed to cold. It then starts to turn blue, and once the nipple is warmed up, and it returns back to its normal pink color. Research by Anderson, Held, and Wright found that oftentimes mothers with Raynaud's are wrongly diagnosed with candidiasis of the nipple. Raynaud's, as you might imagine, is very painful to the mother. Stress can precipitate the vasospasm. As you can imagine, a mother having a new baby is under a great deal of stress. Diagnosis of Raynaud's is done through observing the color changes of the nipple as you see in the picture on the right. Treatment for Raynaud's phenomenon is nifedipine 30 milligrams slow release per day for 2 weeks. Nifedipine is a calcium channel blocker and vasodilator. Multiple research articles have been published discussing the use of this treatment. There are not any side effects in using this medication, and moms should continue to breastfeed the baby as the medication does not transfer through the breast milk. In addition to nifedipine, moms can take ibuprofen and apply warmth to the breast to help alleviate discomfort. Sometimes, the Raynaud's phenomenon does not clear up after one treatment of the nifedipine, and it can be necessary for mom to take the nifedipine 2 and 3 times. But all of the literature that is out there says that after 3 treatments with 2 weeks at a time of the nifedipine, symptoms of the Raynaud's phenomenon typically clear up and go away, and mom does not have any other difficulty throughout the duration of her breastfeeding relationship with her baby. The last thing I want to talk about is inflammatory breast cancer. This is the red flag diagnosis you do not want to miss. You may never see this in your practice, but if you do, you need to be aware of the signs and symptoms. Oftentimes, you will see a breast and think it to be mastitis due to the redness and inflammation in the breast, with the absence of a mass. Some of the differences between mastitis and breast cancer are a lack of fever and patients not responding to antibiotic treatment. I do want to point out that research shows that breastfeeding is one of the few potentially modifiable factors that help prevent breast cancer. There have been 2 large meta-analysis studies that have concluded that breastfeeding provides a protective function against breast cancer. As a provider working with a woman of childbearing age, you should be promoting breastfeeding. Other modules go more in depth on the health benefits of breastfeeding. Know that your attitudes towards breastfeeding can make a difference in mothers' and families' choices to breastfeed. Back to talking about breast cancer. Peau d'orange is a very obvious sign of inflammatory breast cancer. The image you see here is a classic example. The skin of the breast looks like the peel of an orange. You will also notice in this picture that the nipple has become inverted. If you see a patient with this presentation, you need to refer them to a breast cancer specialist immediately. Breast cancer is one of the very, very few reasons a mother would need to wean her baby. The chemotherapeutic medications used to treat breast cancer are passed on in the breast milk and are very harmful to baby. We have just spent a lot of time talking about various conditions that affect breastfeeding women. Throughout, I have mentioned utilizing the use of an international board-certified lactation consultant to help solve breastfeeding issues and provide support for the dyad. I would like to introduce you to Renee Moore, an IBCLC here in Phoenix. Renee has 4 years experience working as a IBCLC. Renee has also spent many years as a La Leche League leader and still works as a La Leche League leader today. She provides support to moms and babies throughout Phoenix and the surrounding areas.
I want to give you some background information about IBCLCs. We are governed by the International Board of Lactation Consultant Examiners. IBCLCs exist around the world, and IBCLC is considered the gold standard in breastfeeding care with a master's level education specific to lactation. More information can be found on the International Board of Lactation Consultant website. Essentially, one must perform 90 hours in lactation-specific coursework, have a certain number of college classes in specific areas, and complete 1,000 hours of clinical work either by shadowing other IBCLCs or working in peer counseling to be able to sit for the exam. Currently, the exam is given twice per year. An individual wishing to take the exam must apply to do so. If you pass the exam, you hold the IBCLC distinction. It is important to note that you will want to work with an individual with IBCLC distinction. Currently, anyone can call themselves a lactation consultant, but only those individuals who have applied and passed the IBCLC exam are able to hold the distinction of IBCLC. Our professional organization is the International Lactation Consultants Association. ILCA holds yearly conferences, provides grants for lactation research, and provides supports for members worldwide. As IBCLCs, we work to promote, protect, and support breastfeeding. The International Board of Lactation Consultant Examiners has outlined our scope of practice. We are not nurses or doctors. Instead, we serve the role of providing support and guidance for the breastfeeding dyad. Think of us as a specialized subset of the healthcare community. We have much experience and knowledge and want to work with you to provide evidence-based care for patients. Kara has done a great job of outlining various breast conditions you might see. As an IBCLC, I have seen all of these conditions. In the case of patients with mastitis, candidiasis, abscess, and breast cancer, we refer to primary care providers right away to treat the condition and then work with mother and baby to figure out what is the root cause of the condition. Does baby have a bad latch? Does mother's anatomy not work well with baby's anatomy? Is mother breastfeeding on cue? Is there a source of contamination that the mother is not aware of? We make assessments of both mom and baby. Then we work to implement a care plan to improve breastfeeding. We work with patients to improve positioning and latch, and we also work to provide support. A Cochrane review showed that one of the things that helps a mother to initiate and support breastfeeding is having support from both her family and from the community. Many IBCLCs make home visits to assess the entire situation of the family. We have insight into the family support system, the family dynamic, the feelings of the mother and father. We also have assessment skills to look for indications of what might not be working in the breastfeeding relationship. For example, in a mother with mastitis, I would first assess the baby's latch. Oftentimes, a mother that has recurrent mastitis is an indication that the baby has a tongue tie or other latch issue. I would also work with the mother on positioning of the infant. There are a variety of positions a mother can utilize to help drain milk from the breast. I teach patients breast massage to aid in emptying of the breast. Interestingly, in other countries such as Russia and Japan, women seek breast massage specialists to help prevent plugged ducts and stop the onset of mastitis. I also work with moms on teaching hand expression of their milk to help symptoms of engorgement and getting baby to the breast. I encourage you to find and establish a working relationship with IBCLCs in your area. You may see an increasing number of patients who are breastfeeding. We provide support pre- and post-natal and want to be a part of the healthcare team providing care for moms and babies. The International Lactation Consultants Association has a tool on their website to help locate a lactation consultant anywhere in the world. All you need to do is type in your location and their tool will bring up a list of lactation consultants in your area. Another way to connect with IBCLCs in your area is to contact the local Lactation Consultants Association. Phoenix is home to the Central Arizona Lactation Consultants Association. Our chapter has monthly meetings and works with the community to provide education and support to both IBCLCs and other healthcare providers. You will also want to be aware of other resources in your community that promote breastfeeding. La Leche League is an international organization that has been around for over 60 years. La Leche League holds free meetings to provide support to expectant, new, and nursing mothers. Finding the local La Leche League chapter in your community to refer patients to will be very helpful. Breastfeeding USA is another resource similar to La Leche League. Both Breastfeeding USA and La Leche League train their leaders to provide support for breastfeeding issues. This is a free community resource that can be utilized by providers and patients. I highly encourage you to take an active role in supporting and promoting breastfeeding within your practice. You, just as much as I, play an active role in helping to increase breastfeeding rates. Thank you for your time.